we need a motion.
So move.
Allow.
Move the motion.
Second.
All those in favor say aye to allow them to withdraw their bills. All those opposed, raise your hands in the icon place. The motion passes unanimously. And I'm going to open up my reactions. No, my participants, is it? Participants, so I can see what you've done. Good, okay. Delegate House Bill, House Bill 5, Tyler.
House Bill 5, Cemeteries, Perpetual Care, Distribution from Perpetual Care Trust Fund, would authorize certain regulated private cemeteries to draw from their Perpetual Care Trust Fund to cover certain maintenance and upkeep costs. There was an amendment offered and adopted in subcommittee that would require their a certain amount of fixed income sources to make up that trust fund.
Delegate Rosenberg.
Sorry, this is similar to language that we, to legislation that we adopted unanimously last session. As Tyler indicated, there is compromise language in terms of tightening how the money can be spent, and that there must be a balanced portfolio, and we would move the amendment and then favorable on the bill.
Is there a second?
Second.
Is there a discussion on the amendment? All those in favor say aye. All those opposed, no. Please raise your hands in the screen. The amendment passes unanimously. Is there a second?
Move the
on
bill as amended.
Second.
Second.
Any discussion on the bill as amended? All those in favor say aye. All those opposed, no. The ayes have it. The bill passes unanimously since I see no hands in the participant column. Okay. It's nice that there are a few easy things on the list today. House Bill 78.
Do you want 28?
28. I keep mixing up those two numbers. Yes. Aaron.
House Bill 28 requires applicants for the renewal of a license or certificate issued by a health occupations board to attest to completion of an approved implicit bias training program for the first time they renew their license or certificate after April 1st, 2022. Beginning in fiscal 2023, the governor must include in the annual budget bill an appropriation for the Office of Minority Health and Health Disparities that is the greater of either $1,788,314 or 0.012% of the total funds appropriated to the Department of Health in that fiscal year. There are amendments that were adopted in the Public Health and Minority Health Disparities Subcommittee that clarify the required appropriation to the Office of Minority Health Disparities and clarify that the implicit bias training only applies to an applicant's first license renewal. And aside from that amendment, there's also a separate amendment that's being offered by Delegate Payne-Melnick. And Delegate Payne-Melnick's amendment would add to the healthcare disparities policy report card a provision that would include information on the racial and ethnic disparities in morbidity and mortality rates for dementia. This amendment was added on the Senate cross-file.
Delegate Payne-Melnick.
Thank you, Chairman. The bill passed unanimous. We had a discussion regarding the training. We passed a similar bill last session regarding the implicit bias training for healthcare providers that dealt with prenatal care. So there are already similar programs that have been developed by the University of Maryland, by Hopkins, that are widely accepted. The bill does describe that the Office of Minority Health must approve, and it must be together in coordination with the boards and with a program that is actually highly regarded and accepted. So I move the amendments.
Second. Thank you. Is there discussion? Seeing no, Delegate Krebs, is your hand up to discuss? And then Delegate Morgan.
I had a question. I mean, you mentioned about, and I just read the bill again today, on this perinatal care facility, we passed that, I guess it just started January 1st. Who put that program together? And will that be the same program as this? And where did that program?
It will be a different program. Delegate Krebs, did you get the information that was sent to you on Friday by Erin? She sent it to your email.
What was it?
Erin?
I went through all my email this week. Tell me what I was supposed to get.
I sent it Friday during the back.
Describe what
You're
it was.
muted, Aaron.
Describe what you sent.
Aaron Hopwood, you're muted.
Yeah, so I sent you just more of a description of the bill, that it would be run through the linguistic and competency program, describing to you current law in terms of how that program already provides implicit bias training for healthcare providers. I believe one of your concerns was that just the content of what the program would provide. And this was geared towards healthcare providers, not necessarily educators. And then I sent you a link to a current program being offered under by the University of Maryland Medical School. And I sent that yesterday.
And I'm going to tell you, I went through all my email. I didn't get any of that. I don't
Okay.
know why.
I'll resend, or if you want to.
Where did you send it to?
Let me look through my sent.
That's all right. That's all right. I just was trying to figure out, again, what was in it. And I didn't realize we already had it for perinatal. Madam Chair, I'd like to look at this stuff because I want to just see what we have in mind with this training. I raised a concern about what would be included in it, who would be putting it together. And
But we answered that already. The person, it says the Cultural and Linguistic Healthcare Professional Competency Program will be in coordination with the Office of Minority Health and Health Disparity, which is an office right now under this administration, and it will be an office there in government that has an executive director, and they will, it says, must identify and approve implicit bias training program. So the Office of Minority Health must identify it and approve it. But then it goes on to say it must, not discretionary, be recognized by a health occupations board or accredited by the Accreditation Council for Continuing Medical Education. So it has a lot of checks and balances. But what I'm saying to you is that there are already programs that are highly regarded and accepted regarding implicit bias that are designed for healthcare professionals, which is a big difference because this is dealing with healthcare. And Hopkins is one that is leading, actually, and then the University of Maryland as well. So we're not prescriptive in this bill. We left it open because we want them to design it with whatever is best practice out there. But the bill is carefully defined and worded to say that the Office of Minority Health and Health Disparity must identify and approve this course with the boards and must be accredited. We left it.
I appreciate that, but that didn't answer my question. I wanted to see content of something.
So Delegate Krebs, I sent you a link. It was yesterday, 9/24, to susan.krebs@house.state.md.us.
Okay, that I don't look at that email. I'm sorry. Look at
Oh.
the other two emails, but which I went through. I'll have to find that. My laptop's closed up. Again, I'm looking for just an example, and this example of the perinatal care would have been helpful. And I mean, I don't care who approves it and all this kind. I wanted just to see what we're talking about. So I'm sorry that I didn't.
So if offline you want to email me the correct email address, I could get it to you right now. I could just forward it to you. So go ahead and email me and I'll forward
If
it.
you want, we can put this bill to the end and come back to it, and I'll give you a minute while Erin sends you the email again to an email that you'll read, and we can give you
That's all
some
right.
time
Just,
if you like.
just move on. I can't keep voting and read an email and send an email. So just continue on. I just would like to see what this looks like, but I'm sorry that I inconvenienced everyone.
Well, it's not an
Okay.
inconvenience, but there'll be Erin send it to you already. If you have a minute to look at it, that would be great. we can really hold it. It would take you just a minute for you to see.
My
what's in
laptop
it.
is all packed, ready to go. That's what my laptop computer,
Okay,
it would be impossible for me to get all
all
that.
right. Okay,
The
so
Delegate Morgan, Delegate Morgan.
Great, thank you, Madam Chair. Is this curriculum, is it going to be available to the public for viewing?
it will be available but to the public for viewing because it has to be recognized by the health occupation boards, which we have about 22 of them, I believe. So it will be available to the public. It will be on their website, like the other programs that are actually provided.
Okay, so anyone in the public can view it? Okay. And then my question was about the fiscal note.
Like you can view anything right now. Yeah.
Okay, and my question was about the fiscal note. Looks like it goes up year after year. It's like what, 2 million, I believe. Is that right?
It says the Maryland Department of Health General Fund expenditure increased by $290,000 in fiscal year 2023. And then it goes up to 556 in fiscal year 2026 to meet the appropriation. So it
So
comes
that's about
also
the
from
appropriation to the, that's about the mandatory appropriation to the Office of Minority Health and Health Disparities.
Yep, because, and that is Delegate Morgan, that is about what they are getting right now. So we chose what they're getting right now and what they have gotten over the last few years. So it's essentially what the program, the Office of Minority Health and Health Disparity needs to be able to run the office.
Okay, thank you.
My pleasure.
Okay, so are you saying that that is not the fiscal note for this bill? That is really the fiscal note for the Office of Minority Health Disparities? I'm a little
Yes,
confused.
Yes, because we're mandating their appropriations. We're mandating it.
Okay, thank you.
My pleasure.
Okay, on the amendment, Delegate
Chairman.
Kipke, Delegate Saab and Delegate Kipke, in that order, please.
Thank you. Just quick question. So on the mandate part, so is it mandated now, or this is going to mandate the 1.7 million to be put in? How is it getting funded now?
It is not mandated. It is not mandated now. The bill intends for the mandated appropriations of the Office of Minority Health and Health Disparities to be permanent.
And that money
So
will
it
not
can
be,
have a budget.
that money will not be only spent on this program. It will be just for the entire program.
It's for the Office of Minority Health and Health Disparities, which its mission is to reduce the health disparities in our state. In some of them, you can look at the page, the fiscal note. If you look at the end, Delegate Saab, look at the appendix for the health disparities, and you'll see the health disparities in Maryland, and you'll clearly see the differences between Black and brown and white, and why that office is needed, and why this money is needed.
Thank you.
My pleasure.
Delegate Kipke, you've put your hand down. Do you want to put it back up?
Well,
You were in
if I
line.
could ask a question, I'm just confused over the money. In the bill, it says basically $8 million as a mandated expenditure. And then you look at the fiscal note, and the fiscal note doesn't seem to reflect that. It has a much smaller amount of money. I'm just confused. Can anybody explain? Is the 1.8 what is existent, what is currently budgeted? And then these dollar amounts are what will increase?
Yes, the it will be at least 1.788 or 0.012% will be what is in the budget that will go for the office.
And that's already, that's in this year's budget?
Yes, it is. It's my understanding. Yes, it's the same
Okay.
amount.
Okay, thank you.
My pleasure.
Aaron, do you have anything to add to this? Okay. Delegate Rosenberg.
I believe I'm reiterating what was just said, but just to say it again, that the bill mandates funding at the existing level with an adjustment based on growth in the overall growth in the budget. So that's why there's this difference between the big number we're hearing and what the fiscal note says, because the fiscal
Yeah.
note reflects increase from the current level.
That is correct.
I believe that's what's.
That is correct, Delegate Rosenberg. Actually, if you read the fiscal note, page 1 on the fiscal summary, it says that future years reflect growth in the Maryland Department of Health appropriations. So that's what it is. It's right there on the fiscal summary.
Okay, are we all clear on that? Okay, you can take your hand down, Delegate Rosenberg. On the amendment, all those in favor say aye. All those opposed, no. Raise your hand in the box. And Delegate Krebs, you need to take yours down from asking to be recognized, but if you want to vote against the amendment, that's fine. I just want to be clear what you're voting on. Okay, the amendment appears to be passing unanimously.
Move the bill.
Second.
Second.
Discussion on the bill. All those in favor say aye. All those opposed, please raise your hand. I see Delegate Krebs, Delegate Saab, Delegate Kipke, Delegate Chisholm, Delegate Morgan.
Shalega can't raise her hand. It doesn't have that feature on my phone, so I'm a no.
Delegate Riley and Delegate Shalega. Okay, so it's a straight party vote. Is that correct? Did I miss anybody? Okay, that's fine.
It's a straight philosophical vote because I don't understand the fiscal impact, but it's written 3 different places. Philosophical.
Okay. Whatever you say, Delegate Krebs. The bill passes. Although I didn't count the votes. Can somebody count the votes for me? We don't usually have that many people voting against a bill, so how many were in favor? Staff?
17 in favor and 7 opposed.
Excellent, thank you. So we're all here. Next, we have House Bill 78. Aaron.
This bill establishes the Maryland Commission on Health Equity to employ a health equity framework in specified examinations, provide advice on issues of racial, ethnic, cultural, and socioeconomic health disparities, facilitate coordination of expertise and experience in developing a comprehensive health equity plan addressing the social determinants of health, and set goals for health equity and prepare a plan for the state to achieve health equity in alignment with other statewide planning activities. There are amendments that were adopted in the Public Health and Minority Health Disparities Subcommittee that add the Maryland Insurance Commissioner and a representative of the Maryland Association on County Health Officers to the commission, and adds the impact of food insecurity on the health of residents of the state as part of the health equity framework.
Delegate Peña-Melnick.
We discussed this bill in subcommittee, and in subcommittee, I believe, and Erin, correct me if I'm wrong, it was actually unanimous. Am I correct?
Yes, it was discussed on February 2nd. It was unanimous.
It was unanimous in subcommittee. So
Okay,
I
would you like to move
the bill.
the
Yeah, I
amendment?
moved the bill. I moved the amendment.
Second.
Discussion on the amendment. All those in favor say aye. Oh, I see a hand up. Delegate Saab, did you have a question or a discussion, or is it just a
I just have
holdover?
No. It's just a quick
Question.
on the name, and it might not be related to this particular bill, but I thought we don't use names in our, I've seen a couple bills with acts and names. I was just curious. I mean, I have a lot of respect to the name. I was just curious if somebody want to comment on that.
At great cost to my sensibilities, I'm doing this in a number of limited cases. I'm
Okay.
not happy, but I am not choosing to fight on this issue at this time on some small number of bills.
Thank you. I was just
Okay.
curious.
I
And if
haven't
I-
changed my opinion of this concept.
And I want to thank the chairman for allowing this. As we all know, we served with Senator Shirley Nathan Pulliam, someone who worked very hard on health equity. And, you know, she's alive. And I feel like she deserves the honor and the respect while she's alive. She won't enjoy it when we go to her grave and take flowers. I feel like you tell people when you love them when they're alive. And this is a great way to honor her, because she told us for many years, and oftentimes she wasn't taken seriously. And I think that the pandemic has really shown that she was right all along. And this is a beautiful gesture for this committee, for the General Assembly, to honor an amazing human being that did so much, and it will leave an amazing legacy. And I thank the chairman for being open to it, because she's so deserving.
The chairman served with her for many years. She was on the insurance subcommittee that I chaired. And so I will just say that she was ahead of her time on this issue. There's no doubt about it. She is a
Indeed.
pioneer in this. So that said, I still hate doing it. So thank you for trying to keep me honest, Delegate Saab. All those in favor of the amendment say aye. All those opposed, no. Raise your hand. On the bill as amended,
So
would
moved.
you, is there a second?
Second.
Second.
Discussion? No discussion? Okay. All those in favor say aye. All those opposed, no. Please raise your hands. I've got Delegate Kipke, Delegate Saab, Delegate Chisholm, Delegate Morgan, Delegate Riley. I'm guessing Delegate Shalega. There's, I see your hand waving at me. Good. Delegate Shalega. Did I catch Delegate Krebs on that list I read out? I don't want to miss
Please
anyone.
do.
I'm not.
Catch me on the list. I couldn't get my hand up. I couldn't find it.
Delegate Krebs, your hand is up. It's there. Okay. I think we got it. All right. So I'm going to guess that
And
that's this.
Shalega, I assume.
We had a discussion of that. We
Yes.
said yes, and we watched her wave her hand at us on her camera,
Okay.
which was perfect. Okay. So again, the vote, I believe, is 17-7 on this one. Thank you all. House Bill 123. Lisa, isn't it nice to see this bill here?
This bill expands the definition of telehealth for both Medicaid and commercial carriers. It requires Medicaid and carriers to reimburse for a covered service appropriately provided through telehealth on the same basis and at the same rate as if the service was delivered in person from July 1st, 2021 to June 30th, 2023. And it requires the Maryland Healthcare Commission to study the utilization, cost, and effectiveness of telehealth and report back to the General Assembly by December 31st, 2023. No, that's wrong. 2022. Sorry.
Delegate Cullison.
There are several
Oh,
amendments
sorry.
to the bill.
Thank you.
That's okay. Amendment number 1 makes technical changes. Amendment 2 reorganizes the telehealth provisions for Medicaid by defining healthcare provider to mean a person licensed, certified, or otherwise authorized to practice healthcare under the health occupations article, a mental health and substance use disorder program, a person licensed to provide developmental disability or individual support services, or a provider of long-term care services. The amendments expand the definition of telehealth for 2 years to include the use of audio-only telephone conversations. They include provisions of the insurance article that were previously incorporated by cross-reference. Require that if MDH specifies by regulations the types of healthcare providers eligible to receive Medicaid reimbursement for telehealth services, that MDH include all types of healthcare providers that appropriately provide telehealth in the regulations. Specifies that for 2 years, Medicaid will reimburse for telehealth at the same rate as in-person visits, but that Medicaid is not required to reimburse a clinic facility fee unless the healthcare service is provided by a healthcare provider not authorized to bill a professional fee, or they also do not need to reimburse a room and board fee. The amendments specify that Medicaid may not require an insured patient to use telehealth in lieu of in-person service delivery for behavioral health services or require the use of a designated third-party vendor as a condition for reimbursement, and provide that the Medicaid reimbursement provisions may not be construed to supersede the authority of the Health Services Cost Review Commission to set appropriate rates for facility fees. Amendments 5 and 6 make similar changes to the definition of telehealth and coverage for telehealth services for commercial carriers as were made for Medicaid. And Amendment 7 repeals a study requirement that was specific to substance use disorder and instead requires the Maryland Healthcare Commission in consultation as appropriate with HSCRC and the Maryland Insurance Administration to submit a report on the impact of providing telehealth services in accordance with the provisions of the Act. And the amendment also adds legislative intent language.
Delegate Cullison.
Thank you, Lisa. Take a breath. This bill, to put it very succinctly, is going to take the information that we have learned through the process of going through the pandemic forward for the next 2 years, so that we will have the information that we need in the 2023 session to make informed decisions around the appropriate use and reimbursement for telehealth. You know, telehealth has existed as long as telephones have existed, essentially. But, you know, in the last 5 or 6 years, it's become used more frequently. During the pandemic, we saw a spike of over 80% in the use of telehealth because folks were not comfortable going to their doctor's offices. But we need to study what the outcomes have been and will be for as we move forward with this technology. It is a tool that the providers can use, and we want to make sure that that tool is, number one, available to them, but number two, that it's being used appropriately for the best outcomes for the patient. So what the bill does, in very simple terms, is it keeps everything at the status quo level right now, which was determined through the pandemic when the carriers were stepped up and paid for telehealth at the same level as they do as in person. And as we study it, and then we will have recommendations from MHCC in the 2023 session. So with that, I would move the amendments.
Is there a second?
Second.
Is there any discussion of the amendments? Other than the fact that I can picture how much effort that they involved in bringing people together, and am in awe of what you did on this bill, and also of what the sponsor did on this bill to get it to the place that it was when it came to you. Good job, both of you. And all members of the subcommittee as well, because we can't do it without you. All those in favor of the amendment say aye. All those opposed, no. Please raise your hand. Seeing no hands, the amendment, what?
Delegate Bandari moved the bill. I second.
Oh, you're ahead of me. Okay. All those in favor of the bill as amended, say aye. All those opposed, no. Raise your hand. Delegate, should I have your hand there on purpose?
Yeah, I had a question. I figured out where my hand was, but you didn't see it in time for a question.
Okay, would you like to ask your question?
I would like to. Thank you so much, Madam Chair. So Delegate Kipke had an amendment about abortion, teleabortion. I was wondering if we could offer that amendment prior to passing the bill.
I never saw that amendment to this bill, I don't believe. Lisa, am I missing?
We never had that amendment for this bill. There was the school-based health center bill that we had that on, but I don't believe Delegate Kipke ever offered it on this. He's in the pro forma session right now.
Yeah, no, we didn't offer that amendment to this bill because it's not on the list of bills that we were told that was a concern.
So is this, Delegate Kipke, this okay without that amendment?
I don't think it needs to be offered because it's not on that list of bills that you're probably thinking about.
Okay, all right, we can offer it on the floor if we need to. Thank you.
Thank you, Delegate.
You're very welcome. Thank you for clarifying her question, even at that awkward moment. Sorry, I didn't see your hand, Delegate Shalega. Drive safely, you're worrying me. So all those in favor say aye, all those opposed, no, raise your hand. I still see Delegate Shalega's hand there. Do you want to vote yes, Delegate Shalega?
Yes, I want to vote yes. Yes, let me
Okay,
find
good.
my,
That's
oh no,
fine,
now
it's fine. Don't
okay.
worry, as long as we clarify, this is a unanimous bill. I don't want to get it wrong. All members voted for this bill. House Bill 182, Health Occupations Podiatric Physicians. Tyler.
House Bill 182 would change all references in the code of podiatrist to the term podiatric physician and provide for such changes in similar regulations, executive orders, and so forth to be consistent.
Delegate Kelly.
Thank you, Madam Chairman. This is a bill that we brought to the voting session 2 weeks ago. Delegate Hill needed some time to consider an amendment. We did work with Delegate Hill, and Tyler did a great job of researching whether the amendment she was proposing was necessary, and she ended up not pressing the amendment, not submitting the amendment in the subcommittee. So it's coming back here to the full voting session, and it did pass out of the subcommittee unanimously except for one. So with that, I would, unless Delegate Hill wants to add anything, I would move the bill.
Is there a second? Is there discussion? All those, Delegate Shalega, your hand's up again. Is that on purpose?
Yes, I understand that the MedCai is okay with this bill now. Is that true?
No, that's not true.
I would not classify it as okay with. They're certainly not supporting the bill. I think they have an understanding that the committee is moving forward with it since it came out of subcommittee. Delegate Hill, did you want to?
May I?
Delegate Hill, I will recognize you now.
Okay, thank you. And thank you, Chairman Kelly. That was, I think, a very accurate description, and I want to thank you and Tyler for working with me and allowing me to work with you to try and come up with an amendment. I just wanted to share something with the committee. The reason I held the bill is because I have a great deal of discomfort, not with podiatry as a profession or what they do, but with taking a noun, which is physician, which generally applies to people who have gone to medical school, and modifying it with an adjective when it's still a noun to say, that someone who didn't go to medical school is a physician. Where I didn't press the amendment is that cow may be out of the barn and has been for some time. I'm concerned about it here in Maryland, and was talking to a couple of patients earlier and said, our dentist physicians, they said, yeah, our veterinarian physicians, yes, our podiatrist physicians, yes. So that's all there is to it. But when I asked them why, they said because they all go to medical school and then they specialize later, which is actually not true. So I just wanted to be clear, the osteopaths and the allopathic physicians actually go to something called medical school, which is not a specialty school. What we then do in terms of whether we become orthopedists, neurosurgeons, or family practitioners, that's after school. And so without that distinction, the physician no longer, if it ever did, means someone who got a doctorate in medicine. It means something different. And as I said, the cow may be out of the barn, but I think that does lead to confusion. And I would note that the effort of the podiatric specialist for the last several years has been about trying to get the physician put on the name in all states because of the fact that they were not allowed to do physician codes in Medicare, and they couldn't get consistency across the federal to be recognized as physician for coding purposes. They also were in discussion about just going to medical school and making podiatry a subspecialty of medicine, which it is not. It is a field in and of itself because it does not have that broad training. And there was discussion about having to pass the medical board that all other physicians have to pass, and that has gone nowhere. My concern as someone in the field was that it was sort of a backdoor way of getting people to assume you have certain trainings that you don't. There is absolutely nothing wrong or lesser about podiatric training. It is just not the same in any way, shape, or form of what a standard physician has. And the last statement I would make is that, you know, doctors of pharmacy are called pharmacists. Doctors of physical therapy are physical therapists. I had thought doctors of podiatry were podiatrists and doctors of medicine were physicians. With this bill, there is no longer a thing that doctors of medicine are that is distinct from what other doctors are. That's my statement. I wanted people to understand that this really is about clarity and confusion in the public view. And with that, please, you know, go ahead and take the vote.
Okay. I don't think we moved the bill. Did we do that?
I did move it.
Okay, good. And seconded it?
Second.
Good. Okay, so we are actually officially on discussion. I thought we
Yes.
might have gotten there accidentally. So I'm wondering, Tyler or Delegate Kelly, I think that an MD is an MD, and that does not translate to a physician. Only a doctor who goes to medical school is an MD. Is that accurate?
That's the degree. The
That's what
MD
you
is the
earn.
degree.
Mhm.
I think Tyler did a lot of research on this in preparation for subcommittee last week, so he can probably dig in a little deeper as to what's in the Maryland law. But you're absolutely correct, and the conversation that we had in the subcommittee about this was, you know, to the extent that confusion exists, consumers generally think of doctors as doctors anyway, and physician is a word that is an inside baseball kind of word. So the confusion, we decided as a subcommittee that generally this will cause confusion argument didn't have that much merit.
And I would add just, there was a quote from
I was going to
the-
ask Tyler to finish the
Okay.
explanation, and then I'll call on you, Delegate Hill.
Thank you.
So I guess trying to address a few points there, that an MD is the degree that would be awarded for completing medical school. As well, you would get a DO for completing an
Right.
osteopathic school, medical school. And it seems in most instances, once you've completed that medical school training, most people, certainly in the field or familiar with the field, would consider you a physician, is what I've come to understand. But yes, it's a word that very much changes depending on context or has broader meanings, sort of how maybe in common speech, like a children's career day, you wouldn't distinguish lawyer versus attorney. Whereas some people are very strict about, whether you've been admitted to the bar or whether you are practicing, whether you're representing clients. And so that's something that wouldn't be addressed in code, or some of the concerns brought up by Delegate Hill, as well as MedChi and like the Board of Physicians. Those aren't things that can be addressed in code. And then just further for potential confusion, that rule of interpretation for the Maryland Code would show that podiatric physician is a distinct term from physician. And actually there's, in part of when I was looking into amendments, it's used frequently enough that it's referencing specifically to the definitions in health occupations, or it's listing the professions out as separate things, the same way that nurse, dentist, occupational therapist, audiologist are also separate health occupations from physician or podiatrist or podiatric physician, as it would now be called if the bill is adopted and enacted. So those are 2 points that came up, but were addressed those ways.
Thank you. Delegate Hill, then Delegate Krebs.
Thank you. So following up on Tyler's point, I think my part of my concern was that for all other physicians up until now, when we talk about cardiac physician, geriatric physician, any of those are all people who went through DO or MD medical school. And the operative word is physician, the modifier is the specialty. This would be the exception to the rule that the podiatrist is the profession and they use the physician as a modifier. And there are times, for instance, at hospitals where podiatrists have privileges that are not as full as other physicians. And the bylaws will say physicians, blah, 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 and then it'll talk about podiatrists. My concern is that at some point the adjectives invariably get lost. And that's what Tyler was helping me to understand, and whether we have a problem in the code, that once that adjective gets lost and people are just saying physician, or the code is just saying physician. So when we say a physician and a nurse and a psychiatric nurse can admit someone involuntarily to a psychiatric facility, what do we have to do to make clear that a physician means someone with a DO or an MD and not a podiatric physician? Because the whole purpose of this bill from the podiatrist standpoint is at some point to just be called physician, just as cardiac physicians are just called physicians. The preformedicalschool.com, which talks about the advantages of going to podiatric school versus the advantages of going to medical school, makes the point, which I also found in the podiatric literature, that recently the American Podiatric Medical Association started pushing to have podiatry students take the USMLE, which is the examination that allopathic students take to qualify for licensure nationally. And it said the goal is to recognize DPMs, or doctors of podiatric medicine, as physicians rather than an entirely different healthcare field, which is what they are. This may have significant change on the future podiatry school curriculum and examination, because the curriculum and examinations are not the same as what people going through medical school or osteopathic school go through, regardless of whether they specialize later on or not. If that helps to clarify the concerns.
Thank you, Delegate Hill. I'll now turn to Delegate Krebs, then Delegate Kerr.
Thank you, Madam Chair. With regard to what people refer to folks at, I never hear anybody talk about physicians anymore. It's always your cardiologist, it's your dermatologist, it's your OBGYN, it's your podiatrist, it's your NP. I mean, there's so many specialties now. And one thing this committee did a number of years ago is on badges made them say what they were. Not just, I'm a doctor, but I'm the cardiologist. So I think that's helpful, what we've done to it. So I don't think there's any confusion among the public. I just think it's a little bit of a pride turf battle, which I understand. I mean, I get that, but I don't think there's any confusion among the public, because I don't ever refer to a physician as a physician. He's my primary care. He's my cardiologist. He's my ear, nose, and throat. And that's sort of how we refer to doctors now, by their specialties, because they're all specialized. So I don't think it's confusing to anyone. So I thank you for all this information. I've learned lots about physicians and names over this last, how many years, 3-4 years. And thanks to the committee for working through it.
Delegate Kerr, followed by Delegate Barron.
Thank you, Madam Chairman. I would just remind the committee that 2/3 of the states have already adopted this terminology, and there have been no reports of widespread confusion at the level that Delegate Hill is concerned about. And medical professions evolve as time goes on. I would also remind the committee that doctors of osteopathy were not even permitted to practice in Maryland until the 1970s. So I guess that's all I want to add at this point. Thank you, Madam Chair.
Thank you, Delegate. Delegate Barron.
Thank you, Madam Chair. Respectfully, I would like to move the previous question.
I would like to too, but I see Delegate Shalega has a hand up, and I think I would prefer to give everybody a chance to speak. So I'm going to just hold that for a moment. if I'm making some big procedural faux pas, it's possible, but the way the committee operates, Delegate Shalega, I want to let you ask your question.
Thank you, Madam Speaker. So my question is, what's the difference between a podiatrist and an orthopedic surgeon that does foot and ankle?
That for me.
Oh my God.
That'd be for Terry
Would you
Hill
like
or
to handle that?
Tyler.
Tyler.
Probably handle that.
Okay.
So,
It would be different training. You would start. So
How about it would be defined by the scope of practice, which limits a podiatrist.
would probably be the key thing, and then part of how you get in or qualify to the scope of practice would be part of the training ahead of time. You would have to. It would require an MD, medical school, and then certain a general residency program, and then certain specialized surgical, and then within after surgical residencies, you would probably go into further specialized, orthopedic, maybe even specific joint or limb surgery residencies before you would start working completely independently and licensed independently as a orthopedic surgeon, is my understanding. Whereas doctorate of podiatric medicine, you would go to a podiatric medicine school, which is some overlap, but different curriculums in the end. And you would have a podiatric specific residency. Sometimes you can do those generally, or you can also then specialize in podiatric surgery with another residency and then work in that. But there are nuances to the scope of practice that I'll admit I don't have completely under wrapped. If you look at the State Board of Podiatric Examiner website, they have a whole section on settled and ongoing questions about scope of practice. I'm sure that all of the boards have similar issues with, completely finding the finer details and specific cases of where their scope of practice reaches or stops. So you have to go through the scope of practice almost line by line to get into the exact details, but that's an overview of the differences and similarities.
Okay, but is this, I guess my concern is an orthopedic surgeon that does foot and ankle goes to medical school, and I love my podiatrist, so I'm not anti-podiatrist, but I think that's the confusion that I was trying to point out and maybe back up what Dr. Hill said. Thank you for the opportunity.
Delegate Hill in this case, since we're in this context. Okay, Delegate Barron, do you have a question or is your hand just up? And I see Delegate Bhandari has thought up a question while we were talking.
I'm
Delegate
sorry.
Barron?
My hand is still up. I'm sorry. It's from
Okay.
my.
And I apologize if I seemed rude. I'm not trying to be rude. We don't usually do that in this voting session. We let people speak. Okay. Delegate Bhandari.
Yeah, just to Delegate Seliga's question. I think orthopedic surgeons are concerned with bones, muscle, and joint throughout the body, and podiatricians are foot and ankle doctors and surgeons as well. Just to clarify that.
Thank you. Is there any further discussion? So there was a motion, a second. All those in favor of the bill, say aye. All those opposed, please raise your hand in the sidebar. I have Delegate Hill, Delegate Shalega, Delegate Carr, and Delegate Lewis. I have 4 in opposition. Is there anyone I've left out? Okay, so this is a 20-4 vote. Okay, we'll now move on to House Bill 309. Erin.
This bill requires the Director of the Office of Minority Health and Health Disparities to meet with representatives from the Maryland Healthcare Commission and the Department of Health at least annually to examine the collection of health data that includes race and ethnicity information in the state and identify any changes for improving the data that is accessible by the Office of Minority Health and Health Disparities. The Office of Minority Health and Health Disparities must, to the extent authorized under federal and state privacy laws, respond to requests for health data that includes race and ethnicity information within 30 days after receipt of the request. The bill also alters the Healthcare Disparities Policy Report Card and requires each health occupations board to include an application on renewal forms, an option for the applicant to provide their race and ethnicity information and encourage the provision of that information. This was in the Public Health and Minority Health Disparities Subcommittee and was also unanimous.
It was a
Delegate Penny-Melnick?
unanimous vote. Thank you, Chairman. Thank you, Erin. It was a unanimous vote. I move the bill.
Is there any discussion on the bill? Is there a second on the bill?
Second.
Thank you. All those in favor say aye. All those opposed, no. Please raise your hands. The bill passes unanimously. You do know that I announce these things so that you can correct me if I've made a mistake. So feel free to correct me if ever I make a mistake, because I don't know if you don't say something. That's what I'm really asking. House Bill 540, Tyler.
House Bill 540 would enroll Maryland upon the enactment of the Interstate Occupational Therapy Licensure Compact. Maryland would be enrolled into the Interstate Compact.
Delegate Kelly.
This bill had no amendments. It came in really
Actually,
clean.
it had one technical amendment from the sponsor.
Oh.
Just
Yeah,
fixing up some language.
the clarifying. Okay, yeah, that's right. We did adopt that, but it was just clarifying language. So I'll move the amendment first so we can do that.
All those in favor say aye. All those opposed, no. Thank you for the second. I see no hands raised. The amendment passes unanimously.
So with the exception of the technical amendment, it had no amendments. It had all the stakeholders lined up. The OT board was eager to support this, and the subcommittee felt like it was a good direction to be moving to solve some of these interjurisdictional challenges, and it passed unanimously. So with that, I move the bill as amended.
Second.
Thank you. Discussion? All those in favor say aye. All those opposed, no. The ayes have it. It's unanimous.
Sponsor
Bill-
amendment.
Yeah, in some other year. Hopefully next year, Delegate Saab, hopefully. House Bill 598, Erin.
This bill prohibits the Department of Health from conditioning reimbursement of applied behavior analysis services provided to Medicaid recipients under their early and periodic screening, diagnosis, and treatment benefit on the presence or availability of the parent or caregiver in the setting where the ABA services are provided. There was an amendment that was adopted in the Public Health and Minority Health Disparities Subcommittee that provides that Medicaid may establish reasonable standards for the involvement of a parent or caregiver, including requiring notification from the parent or caregiver of their decision not to be present or available when the program provides ABA services to a recipient. The amendments also require the department to adopt regulations to implement the bill.
Delegate Penny-Melnick.
I believe this was unanimous. And
it was.
The amendment, Chairman, came as a result of some of the concerns that two members had. And after that amendment, that was alleviated. So I move the amendment.
Second.
Is there discussion on the amendment? All those in favor say aye. All those opposed, no. Please raise your hands. Amendment passes unanimously.
I move the bill.
Second.
Is there discussion on the bill as amended? All those in favor say aye. All those opposed, please raise your hand. The bill passes unanimously.
Thank you.
House Bill, thank you. 667, Tyler.
House Bill 667 would repeal the state song, Maryland, My Maryland. There are no amendments.
The vote in the committee was unanimous. And we would move
Okay.
the
Second.
Is there discussion on this bill? All those in favor say aye. All those opposed, no.
I have my hand
Wait,
up.
Oh, you do have your hand up there, Delegate Chalega and Delegate Morgan. And actually, it's Morgan first, if you don't mind. He beat you to it.
Please. Yeah, Morgan
Okay.
first.
Go ahead, Delegate Morgan.
I'm sorry, I couldn't get the mute off. Thank you, Madam Chair. I I guess this whole removal of the state song, it kind of reminds me of the Tawney statute from a few years ago, where you had, you know, some prominent Democrats and then some prominent Republicans. I believe Delegate Slago was one of them that was actually turned in a bill to remove the Tawney statute. And then you had people like myself and Senator Miller that wanted to keep it. And the reason why I always thought that it was important to keep the Tawney statute, even though, you know, for those that don't know, we used to have a big statue out in front of the State House for Justice Tawney, who also authored the Dred Scott decision, which was a horrible, horrible decision, one of the worst ones the Supreme Court ever authored. But he later in life recanted that. And to me, the reason why the statue should have stayed there was you couldn't tell the story of Thurgood Marshall correctly without telling the story of Tawney. So you had this horrible guy that was out that offered the Dred Scott decision. And 100 years later, you had an African-American serving in the same capacity that he was. And to me, that was the celebration for it, because no other country in the world could have actually accomplished that than here. So I worry that this opens up the floodgate yet again. We're removing the state song. I remember years that we've sat in committee and debated remove the state song for hours upon hours. And this year it just felt like we had 3 bills, we squished them together, and we had basically like a 20-minute hearing on it. And I look, and I remember during the testimony of it, the witnesses talked about removing the state flag and the state seal. So I'm just kind of wondering, like, where do we draw the line at on those?
I'm not sure of whom you're asking that question.
Yeah, I guess maybe I guess that was more of a statement of explaining my vote.
Okay, I just wanted to make sure that I was addressing it appropriately. Okay, thank you for that. Delegate Shalega, followed by Delegate Lewis Young.
Thank you, Madam Chair. So I thank you for letting me hold this bill for a week. And I did my homework. I'm here pulled up to the garage. All my homework's on my desk. I can't say the dog ate my homework, but I can remember my homework. So I did research this song, and the first time it was brought up, I think in 1935, Governor Harry Nice was a Republican and he vetoed it. And but as part of his statement, he said, if people like the song, they'll play it and sing it. And if they don't, they won't. Obviously, the lyrics that are calling President Lincoln a despot and using the words that John Wilkes Booth used when he murdered President Lincoln, you know, for a Republican, our first Republican president, I find them offensive. And, you know, so I was leaning towards, well, should we repeal this song? But as I reflected on it, I thought, you know, we have a lot of cancel culture going on and we're canceling everything. And, you know, as I look at personal heroes of mine of the past, you know, David from the Old Testament, you know, who committed adultery and then had Bathsheba's husband killed, you know, we didn't cancel him out of the Bible, but showed that that's a man with flaws. So I'd like to relegate this song to history, but I'm not going to be able to vote to repeal it as the song. We could call it, if you wanted to call it the historic song, I would vote for that, but not for the repeal.
Okay, thank you, Delegate Shalega. Delegate Morgan is next. Oh, wait, no, okay. Delegate Lewis Young is next.
Thank you, Madam Chair. I would like to share some research that I've done since I had an attempt to change the state song in 2016. Since 1974, there have been 10 attempts to change the state song. But let's go back to the origins. It wasn't a song, it was a poem. It was a poem written by James Ryder Randall, formerly a Maryland resident, but he moved to Louisiana and he tried to join the Confederate Army. He was rejected for health reasons, but he was a loyal subject of the Confederacy. He wrote the song in a moment of anger. The Union had marched through Baltimore, and a friend of his was killed in a riot. That night, he wrote the poem in a period of anger. So not fast forward to 1939, which for the historians among us was one of the most racist periods in Maryland. And that's when the poem became a song. As I mentioned, this is now the 10th approach. In 2016, it actually passed in the Senate. Because it was my cross file. And former President Mike Miller, after many, many years, agreed to do it. That was a major milestone. The House didn't do it. Now's our opportunity. For the past couple of attempts, the argument has not been over whether or not to repeal the song, but how to replace it. So this bill smartly doesn't address the replacement. It repeals the song. There are some symbols in our history that must go, and we can retain the history, but remove the symbol. When a constituent of mine first mentioned how horrific he found this song, and I read the words, it made me think of my reaction when I see a Nazi swastika. That's something that should never be a state flag. And by the way, this is the only state song in the United States that was a former battle hymn and advocates the overthrow of the Union, the only one. For many of those reasons, I hope we finally repeal the state song. Thank you.
Thank you. Let's see, I have Delegate Rosenberg next, then Delegate Krebs and Delegate Morgan.
Thank you, Madam Chair. When a song, a poem, includes among its lyrics, among its verse, references to Northern scum, and when it speaks of Sic Semper, which, as we all know, is what John Wilkes Booth said when he crossed the stage after shooting Lincoln in Ford's Theater, it is not cancel culture to say our state should not be represented, should not be honoring these words as our state song. And in addition, if Tawny may have recanted what he wrote, his decision in Dred Scott, but John Wilkes Booth never recanted what he said. And so I think this is a worthy piece of legislation and urge a favorable report. Thank you.
Thank you. Delegate Krebs, please take your hands down when you're done speaking. And then Delegate Morgan.
Thank you, Madam Chair. And I'm very hopeful this is the very last time that we have to have this song or this thing on our to-do list. As was mentioned 10 times, we've listened to special summer studies on this, bill hearings that lasted hours and hours. Many of you on the committee have not been through a fraction of what some of us old timers have been through. And I will just say, if we had spent a fraction of this time on something of any importance moving forward for the very same group of people that we're supposed to be, looking out for, we would have been done something positive. To me, the song isn't sung anywhere anymore. I never even knew what the words were until people brought it to our attention. I still don't really get it if I had to listen to it again. It is a historic song. I don't care if it ever comes back again, but to cancel it out and to just call it the historic song. But the amount of time that we have spent and the energy spent on this has been just blows my mind. And I think we should start looking forward to finding solutions to problems versus keep looking in the past, figuring out what people said 50 years ago, 100 years ago. It really doesn't matter. Let's move forward and just do something positive, because it's not really helping anybody. I don't think anything's going to change for anyone when this song changes, because we don't use it anywhere anyway. So I'm voting no, just but I hope it passes so it never comes back again. So, thank you.
Delegate Morgan, and the last bite at the apple is Delegate Hill. Delegate Morgan, you need to unmute if you want us to hear what you're saying.
Unmute. Sorry, Madam Chair.
It's okay.
Yeah, so my mom gave me this about 4 years ago. I almost forgot about it. And what it was a handwriting contest that I had, and I won first place. And interesting enough, the poem is Maryland, My Maryland. And it doesn't speak of anything that anybody would have any problems with. You know, the part of the song that everyone has an issue with is like verse 4, which is not sung anywhere, that no one even knows. So, I mean, a lot of it, in comparing it to a Nazi swastika, a regime that killed 6.3 million innocent people, I think that's not I don't think that's a comparison you can make with hardly anything. I think this is the PC culture, creeping in, and I'm going to vote no on this bill. Thank you.
Delegate Hill.
Thank you. So first, there are everyday reminders of our racist past. We don't need a song to remind us of it. There are symbols and realities all around us. Number two, the great lost cause was lost. Let's move on. And number three, as far as Justice Taney was concerned, he was not honored with a statue because he was a particularly distinguished Maryland justice. He was honored with the statue because of the racist movement at the time that the statue was contracted for, and because he stood for segregation forever. Thank you.
And having all had our chance to say what we needed to say to explain our votes, I believe this was moved and seconded. So I'm going to ask for people in favor to say aye, and anyone opposed, please raise your hand in the panel and I will read those names. Delegate Shalega, Delegate Chisholm, Delegate Krebs, Delegate Kipke, Delegate Morgan, Delegate Riley, Delegate Saab. Okay.
Madam Chairman?
Yes, sir.
Would you, since we repealed it, obviously, would you mind singing it one last time for us so we can hear it?
If I did, you'd all sign out so you wouldn't have to listen to me sing.
Because I want to feel better about it.
Might change your vote, actually. Who knows?
Actually, I would have voted for it if there was an amendment that would also say, do not ever replace it with anything.
I might have done that too. I might have been okay going along with that. Maybe
Saab wouldn't have voted for it. Don't believe him.
I don't know.
You don't know me well, Terry.
If my colleagues in the other party wish to put that amendment forward at this moment so that they can vote for the bill, I'd be happy to do it if you all are in agreement. Okay. The bill passes minus those 7 votes. Next is House Bill 674. Lisa.
This bill requires the Maryland Department of Health to make site visits and conduct full surveys of the licensed nursing home if ownership of the nursing home is transferred to a person that does not own or operate another nursing home in the state at the time of the transfer. There are amendments. Amendment 1 is technical, and Amendment 2 specifies that the first full survey be conducted within 3 months after the date of transfer, and that an on-site follow-up survey be conducted within 120 days after the full survey is completed.
Delegate Kelly.
Yes, so the subcommittee liked this bill and liked the amendment. The amendment was worked out just to make the timeline work a little bit more efficiently, which we appreciated coming from the sponsor. And it also clarifies, so it'll be 3 months for the survey, and then within 120 days for a site visit that is explicit in the amendment, be unannounced, to the question that Delegate Hill raised during the hearing. With that, the amendment passed unanimously, as did the bill. Move the amendment.
Is there discussion of the amendment? Is there a second on the amendment?
Second.
All those in favor say aye. All those opposed, no. The ayes have it. The amendment passes unanimously.
And move the bill as amended.
Second.
Discussion? All those in favor say aye. All those opposed, no. The ayes have it. Actually, I meant raise your hand, but the ayes still have it, and it is still unanimous. Okay, next we have House Bill 689. Aaron?
House Bill 689 authorizes a licensed certified social worker clinical in conjunction with a physician to certify an individual for involuntary admission to a facility or a Veterans Administration hospital. There are amendments that were adopted in Public Health and Minority Health Disparities Subcommittee that authorize certified social workers clinical and licensed clinical professional counselors in conjunction with a physician to certify a parent or guardian's application for a minor for admission to a facility, and authorizes licensed clinical professional counselors in conjunction with a physician to certify an individual for involuntary admission to a facility. It was in Public Health.
Delegate Penumelnik.
Thank you, Chairman. The bill passed. Actually, it also passed the Senate, and it was unanimous. And the primary sponsor came, and I allowed her to come to the committee, and she was able to share with the subcommittee why this was important. So we learned this: social workers provide most of the behavioral health services in Maryland, and paperwork for the authorization of involuntary admission must be completed within 12 hours of the patient being admitted to the hospital. And they're busy, and most of the time the person around is the social worker. So I move the bill.
Second.
The amendment.
Move the
Is there a
amendment.
timing amendment? Yeah,
I second the amendment, Madam Chair.
thank you. Is there discussion on the
Sorry about
amendment?
that.
That's all right. I'm just trying to keep things straight. All those in favor
Thank you.
say aye. All those opposed, no. The ayes have it. Would you like to
I
move the bill?
Yes, thank you. Move the bill.
Second.
Is there any discussion on the bill as amended? Seeing none, all those in favor say aye. All those opposed, no. Please raise a hand. The bill passes unanimously. House Bill 736.
House Bill 736 enters Maryland into the Interstate Licensed Professional Counselors Compact. There was an amendment adopted by the Health Occupations and Long-Term Care Subcommittee that would make the bill an emergency.
Delegate Kelly.
Thank you, Madam Chairman. So this is the second of the 4 compact bills that we've considered, and this one also had strong support from the board as well as the administration. They requested the emergency bill amendment, making it the amendment to make it an emergency bill, which passed unanimously within the subcommittee. So I move the amendment.
Second.
Is there any discussion on the amendment? All those in favor say aye. All those opposed, no. The ayes have it. I see no hands.
And I move the bill as amended.
Good. Discussion on the bill as amended. All those in favor say aye. All those opposed, no. Please raise your hands. The ayes have it. It passes unanimously. House Bill 780. Lisa?
House Bill 780 requires the Maryland Health Benefit Exchange in consultation with the Insurance Commissioner and is approved by the Exchange Board to establish and implement a state-based young adult health insurance subsidies pilot program. By January 1st, 2022, the Exchange must adopt regulations implementing the program, and the Exchange must track specified information about the pilot program. There were amendments passed by the Insurance and Pharmaceutical Subcommittee that alter the income eligibility parameters that the Exchange must consider from between 133 and 140% of federal poverty level to between 133 and 400% of the federal poverty level. And then the amendments also authorize the Exchange to designate up to 20 million of the Exchange funds for subsidies rather than requiring the governor to designate $10 million.
Okay. Delegate Cullison.
Thank you, Madam Chairman. So the Maryland Health Benefit Exchange did an analysis 2 years ago of ways that could potentially increase the number of people who are insured in Maryland. One of their recommendations was a project where we would allow subsidies for the population that does not have coverage. One of the most significant populations that does not have coverage, which is the 18 to 34-year-olds. Those are also the least ill, which would, by incorporating them into the insurance pool, would decrease the risk in our insurance pool and ultimately could positively affect insurance rates. Besides in creating healthier people, we would also, or encouraging healthier people, we would also be supporting ourselves economically. The commission, the Maryland Health Insurance Protection Commission has studied this issue and recommended this pilot program for this year. And so what it does, as Lisa explained, is it will use some of the money from the reinsurance program, up to 20 million, to create a pilot where we can examine the effect that providing this subsidy to those folks would have on our overall insurance environment, both in terms of the number of people in the pool and the cost of insurance. So with that, I move the amendments.
Second.
Discussion? All those in favor of the amendment say aye. All those opposed, no. The ayes have it. It's unanimous.
And move the bill as amended.
On the bill?
Second.
Is there any discussion on the bill? All those, oh, I see 3 hands. We'll start with Delegate Kipke, then Morgan, then Saab, then Riley.
Thank you, Madam Chairman. I voted against it in subcommittee, and I do have reservations. Call me a skeptic, but I'm concerned. I'm going to vote for this because I think it's worth trying. Care First expressed some concerns about it. Part of my concerns really relates to the fact that, you know, I don't know if these are actually going to reduce overall rates. I hope it does, and that's why I'm willing to support it to get an idea of where we're going with this. But I think it's really important to remember, which is, you know, what's causing me so much angst. The rates in the individual group became so expensive that it was creating a sort of a catastrophic, you know, problem for people trying to afford their insurance. We're pooling money out of that for something else that you know, could be needed in the future. You know, the money that's available is only, as far as we can see, available for 2 more years, and this $20 million times 2 could be used in those out years should something go wrong with the fund. Nevertheless, you know, I think it's worth at least trying this out to see if it does any of the magic things that advocates have suggested. And it certainly doesn't do any harm to the individual group on the short term. So I just wanted to put that out there to let people know why I'm changing my vote to yes. Thank you.
Thank you.
Delegate Morgan is next, then Delegate Saab.
The question I have, and this came through subcommittee and we've talked about it a good bit, but I still don't understand the theory there that we're going to bring more people, younger people into the market, into the individual market, and therefore it's going to reduce rates. Like, I would understand the actuarial of that, but these are non-paying members. So I don't even know, how's that? Does anybody want to elaborate on that theory?
Delegate Cullison.
Thank you, Madam Chairman. So it's not that they're not paying anything. It's a subsidy program, so that they will be paying something and that money will be going into the insurance market by their presence there. And in the meantime, by virtue of the fact that there is money going into the market attached to what is generally the most healthy group of people in the market, then actuarially The hope is, but it is an experiment. I'll admit to that. It is an experiment. The hope is that it will, because it decreases risk, that it will help to manage premiums. Does that make sense, Delegate?
It makes sense. I just remember the whole thing about the individual market, and that was such a, I don't know, I won't say the word contentious. It was just so problematic because rates were skyrocketing there, double digits per year. So we finally got that under control, and now we're trying to expand the program. And honestly, I do have a little bit of concern is just how we fund the reinsurance market to start with. I mean, we're taxing other people's insurance to provide a benefit for other people's health care. And now we're expanding that. I just don't know if I agree with that. So, thank you.
Let me add to Delegate Cullison's explanation that not only are we having the premium dollars that the Young Invincibles would pay, but the subsidy also brings that amount, whatever that subsidy may be for that individual, up to the amount that the premium costs. So we're getting the full amount of the premium. We're just getting it in a different way. And it is an experiment, and it is for 2 years, and it might not work. But so far, the things that have been recommended have really worked. So I'm optimistic that maybe this too will work. And I've been wrong before, so who knows? I'm not saying anybody really knows, but if you don't do it, you sure don't know. Delegate Cullison, sorry to add that, but I just felt it was important that it's a whole premium, not a part of a premium that actually gets paid, which is where the money comes from that's different. Delegate Kerr.
Thank you, Madam Chairman. This bill attempts to get at the last 6% of Marylanders who are uninsured, and they tend to be that age 19 to 39. So we wonder, why are they not insured? And a lot of times it's that health insurance is not affordable for them. These are people who make up to 400% of the federal poverty level, which is about $51,000, which is about what a college graduate makes right out of school. So this would allow these young professionals, who many of whom are working temp work or a gig economy and stitching together a job until they can build a resume that's attractive enough to catch on with a company that has employer-based insurance. So as others have said, we don't know if this will work, but what we've tried so far has not worked in reaching this 6% of Marylanders. And we should know by the end of the pilot program if this is promising and if we should continue it. Thank you, Madam Chair.
Thank you. I've got Delegate Shalega's hand up, and I think Delegate Kipke meant to take his down.
Thank you, Madam Chair. Isn't this the same group of people that already have a catastrophic option? I guess that question's for Delegate Cullison.
They do, but it's very expensive, and it doesn't cover very much.
Certainly, but I mean, this is $20 million that could be targeted to some of our small businesses that are, would like the catastrophic plan. Where does the catastrophic age out at 30? Age 30, you can't get the catastrophic after that?
Lisa, I have to look at you for that.
Well,
Unmute,
it
Lisa.
doesn't, that's not.
I can look for it. I don't know off the top.
Yeah, I think it's 30 or 32. Yeah, I'm skeptical of spending $20 million of this. I hope you're, Madam Chair, that it works. Thank you.
Okay. Seeing no other hands, no further discussion. All those in favor, are we on the bill at this point?
Move the bill as amended.
Second.
All those in favor say aye. All those opposed, raise your hands. Okay. We have Delegate Chisholm, Delegate Krebs, Delegate Saab, Delegate Shalega, Delegate Morgan, Delegate Riley in opposition to the bill. Which means I presume that there are 18 votes in favor and 6 votes against. So the bill passes. We will now move to House Bill 812. Erin?
This bill requires the Maryland Department of Health to make recommendations to 211 Maryland regarding the establishment of an opt-in mental health services phone call program that requires a call center to make periodic calls to persons who have opted into the program and attempts to connect persons with a mental health provider on request. There's an amendment that authorizes the governor to include in the annual budget an appropriation to the department in an amount sufficient to carry out the bill, and changes the effective date of the bill to July 1st, 2021. And this bill was in Public Health and Minority Health Disparities Subcommittee.
Delegate Penny Melnick.
Thank you. The bill was discussed. It was unanimous, and I move the amendment.
Is there any discussion on the amendments? All those in favor say aye. All those opposed, no. The ayes have it. Unanimous.
I move the bill.
Second. Is there any discussion on the bill as amended? All those in favor say aye. All those opposed, no. Please raise your hands. The bill passes unanimously. House Bill 983. Lisa?
House Bill 983 requires the Maryland Department of Health to develop specified guidelines relating to the restrictions on a personal care visitor and a compassionate care visitor that a nursing home may impose to reduce the spread of COVID-19. There are amendments that were passed by the Health Occupations and Long-Term Care Subcommittee that make the bill an emergency, alter the title, extend the scope of the bill to include catastrophic health emergencies besides COVID-19, and specify that an individual other than a family member or legal guardian can be a compassionate care visitor. The amendments also specify that the guidelines must be consistent with federal requirements, clarify that the required content of the guideline, what the required content of the guidelines is, and require the guidelines to require alternative means of communication with visitors under specified circumstances. And finally, the amendments add legislative intent to balance the physical needs of residents with the mental and spiritual needs of residents during a catastrophic health emergency.
Delegate Kelly.
Thank you, Madam Chairman, and thank you to Lisa for both reading all of those and working tirelessly on all of those amendments. We have 4 bills in the committee this session that deal with, in some way, the issue of visitation in nursing facilities. So this is actually Delegate Lehman's bill. However, we took parts from a number of the other bills and put it into this bill. If you remember from the hearings, there seemed to be a consensus around the idea that having the onus on the department to develop the guidelines was the approach that was going to work, which is why we used Delegate Lehman's bill, because that's where that was starting. But the amendments do a number of things. Lisa just read them, so I'm not going to go through them all, but I just want to make sure you guys understand, since this bill has seen some significant change. It expands it from COVID-19 to include this language, other catastrophic health emergencies. So a future situation, this would also apply to. It requires the development of visitation guidelines and specifically requires it for compassionate care and personal care visits. And then it also takes the part from Delegate Henson's bill that requires, as practicable, utilization of alternate means of communication if visitation isn't possible. In addition to that, it adds this really clear uncodified language that says that the intent of the General Assembly is to balance the physical needs with the mental and spiritual needs of the person with a pretty direct, and makes it an emergency bill so that we can get this in place right away. And also, very importantly, I mentioned that Delegate Lewis Young from our committee had a bill very similar to this, and we are going to name this piece of legislation after her mother, Gloria Dates Lewis. So with that, I will tell you that the committee was very supportive of these amendments, and after a robust discussion of how important we think this is, the amendments passed unanimously. I move the amendments.
Second.
Thank you. Is there any discussion of the amendments? Delegate Shalega, then Delegate Hill.
Thank you, Madam Chair. Delegate Kelly, I'm assuming you took the leading age amendment they wanted about CDC.
I'm not sure exactly what amendment you're talking to, but leading age was very much a part of the development of all of these amendments and was supportive of them. So I think that maybe what they were proposing is a little bit different from what ended up in there, but we're ensuring with these amendments that we are not going to be in contradiction with the federal guidelines.
Okay, and their use, that was my follow-up question, was that you've got leading age and the, healthcare facilities, folks, they're on board with what
They
we're
were
doing
all
here.
on board with this approach. Yes.
Okay, all right, and I'm sorry you're not naming it after my dad, who's in a nursing home.
I think we lost the tail end of what we're saying, but I know this is a very important issue to you and many committee members as well. I'm very glad we're able to move forward on this topic.
Delegate Hill.
Thank you, Madam Chair. So, Madam Chair, I know we have different rules about co-sponsorship, but I'm wondering, since there were pieces taken from Delegate Lewis Young's bill and from Henson's, and the bill is amended anyway, can we add an amendment to put those two sponsors on this bill too?
We don't have different rules about sponsor amendments. We don't do them this year, period. We've done none, to my knowledge, except maybe a delegation bill, which was like in the first week when we were not clear about what the rules were. We have not been doing sponsor amendments, and I am told not to do them. I appreciate that in some ways it doesn't seem to make sense, but the problem is you can't do it selectively, surgically, without all the other people who would like to be sponsors of a bill like this being on it, I believe. So that's the direction that I have.
Thank you.
But thank you. That was a very thoughtful suggestion. So we passed the amendments, or are we on the amendments, Delegate Kelly?
We are on the amendments right now.
And they're moved and seconded. Is there further discussion on the amendments? Seeing none, all those in favor say aye. All those opposed, no. Please raise your hand. Seeing no hands, this is passed unanimously.
We need to move the bill as amended.
Second.
Is there any discussion on the bill as amended? All those in favor say aye. All those opposed, no. Please raise your hands. Seeing no hands, this bill passes unanimously. We are on to the last bill, but don't leave. I have a couple of little announcements. Delegate Cullison, Lisa.
House Bill 1034 repeals the date by which the Prescription Drug Affordability Board must submit a plan of action if drafted to the Legislative Policy Committee for approval. There were no amendments.
Delegate Cullison.
Thank you, Madam Chairman. This is a bill that was just necessary to make sure that they had time, the Prescription Drug Affordability Board had time to complete its work before it was required to give it the information. So it was accepted by the committee unanimously, and I move the bill.
Is there a second?
Second.
Discussion? All those in favor say aye. All those opposed, no. The ayes have it. It's unanimous. And that's the last bill of the day. So let me make a couple announcements so you all know. I should have done this at the beginning, but it turned out not to matter. Delegate Saab, is your hand up?
No, I'm good.
Okay, good. Thank you. My announcement is that as of today, we can vote with much less public notice on bills because we're that close to crossover that will not be 48 hours from here forward. So we will try to do it the day before, as we always have done. We'll try to get a vote list to people as soon as we can. But in particular, when bills get held, we may have to hold extra voting sessions to make sure we're getting all the work out, because we now have 11 days to get the work to the floor. So, and that includes, actually, it doesn't include Monday night, so we're down to 9, but it does include a Saturday, and it may be Mondays as well, but my understanding at this point is it's still 4 days, plus the Saturday of crossover. So that's a little bit of scheduling information for you, not a lot. A little bit of procedural information. Do you have any questions about it, or is there anything else in general that I can answer before I say goodbye? See you tomorrow.
If I may.
Okay, thank you
Chairman,
all, my subcommittee
can you hear
chairmans,
me?
for your leadership, the members of all the subcommittees, which is the members of all, for all your hard work, and for your really good discussion of all the bills. I'm very grateful to have such a great group of people to be working with in this committee. So thank you all.
Can you hear
Goodbye.
me, Chairman? Are you able to hear
You're
me?
adjourned.
No?
We can hear you. We can hear you, Delegate Peña-Melnick.
Don't know why she
can't. Hear you, Jocelyn. We can hear you.
I think my internet is acting up, but I wanted to let you know, those of you that are on the Public Health Subcommittee, that we may need to meet a little more often as well. Thank you.
Thank you.